Yeah, you see a very nice pruning over there. So, and then on the diagram, you also see a pruning as well, like very huge PA and all transfer really small. So, and we'll send to our rheumatology to do the full autoimmune screen. For the pulmonary, usually we will also send for spirometry to just rule out. But I think in this case, you can, it's not going to be secondary to the lung, which is your type 3. So, yeah.
And do you, in the case that every investigation is negative, so do you send them for any genes investigations for any mutation or something like this? Because genes, no.
Which
I mean, you think
unless it's a strong family history of the recurrent type of myopathy, then otherwise I think gene test is the
We tend to send genetic studies for cardiology, right? For cardiomyopathy, both hypertrophic and diabetes, as well as the arrhythmia, so long QT provider. From the material hypertension, not that I remember, yeah. But predominantly we want to screen and make sure that there is no underlying autoimmune disease which is potentially responding to the treatment.
Thank you.
It's a man. It's a man.
Yeah, it's a female. 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 Then is those group lah. Idiopathic pulmonary hypertension. 不用走过去了，避免不要走过去。Yeah.
D-shapes.
Yeah.
This one is just very delicate. This one is very sharp. So this one is glasses. This is exercise.
Hopefully lah. I don't know. I haven't seen enough cases.
100 kg, 5 times.
But they didn't give us the history of that.
I think about primary RV is the ECG shows the movement of the body. This one is that. Glare from the
Yeah. But it's functional.
Function for sure. Yeah.
And we say that TR is not CD. It's not CD. This is a rich man, politician's son. They say there are 2 cases. This is actually this is the assigned one. Right? Right? So this the young man is the add-on one. Just now they told us they have the add-on 2 cases and then. But this one, they're not doing TE. There's no problem. This one, this case, is clearly from hypertension. Yeah. Dilated. Yeah, dilated. You can comment on the mạch.
Yeah.
Dạ. Em xong. Vâng, vâng. Em xong chụp ảnh luôn đó. Vâng, 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 em nhớ. Đấy, kia thì em bảo phải có cả ảnh ngược. Các bạn tình nguyện để cho thông tin thôi. Để vì cái
First presentation.
Yes, several months ago. Have a this year.
Have you done categorization?
This shift it to and we intend to do next week.
Next week.
For Zoom is video.
We have in Vietnam for kilometric market, consider we have process activity and process and
We have a very limited shops, so you just have silent film and the center.
yeah.
Stuff like just I need you have a celestial or mastican or something like this. So in this group of this is very we cannot follow the design or this high risk. This is and I'm glad to ask for the discipline thumbs PAs and severe chapacity also cardiac infusion. Do you ever do the balloon HSF
Now I'm using equicenter and formatting and sales back.
Để sao lúc mình đến tỉnh là viết để sao
I'm not sure because they still use it as number for their period, but not for
not for adult.
Treatment, palliative treatment. So this the BPS because the BPS or stethoscopy or heart shunt, something like this, not only children. Because for lung transplantation is not easy to have an opportunity and also the high cost.
And for this part, if you're gonna do combined heart, which is very difficult. Yeah, the mortality is very high. You gotta be in even Okay, so when I was a fellow in the Clifton Clinic, that was a year where they did 80 heart transplant. They did 3 heart lung. Yeah, so it's not common at all. Yeah, and even then they need both lung. Yeah, so they get 2 lung plus 1 heart. So it's not easy to come by. You need a lot of gunshot to the brain to get a kind of a young patient that you can harvest the lung and the heart. So.
Do you perform the dilatation test, vasoactive test, vasoactive testing when you do the cath lab?
Yes, we do. Yeah.
What yes.
We use inhaled prostacyclin. Yeah, correct.
We haven't had inhaled prostacyclin. What is alloprost or what?
Alloprost.
Alloprost inhale.
That's right. Yeah.
We
but
just have an IV alloprost.
Yeah.
In the past, we have an inhaled alloprost, but now maybe the company supplying not yet in Vietnam. So,
okay.
Do you use nitric oxide or on 100% oxygen for vasodilative testing?
Nitric oxide? Not that I don't think so.
Just
yeah, just
I inhale alloprost.
Yeah.
Do you have a epoprostenol?
IV?
Yes.
At the moment, when I check with our pulmonary hypertension group, we only have 3 patients on long term.
The pump?
The pump.
The subcutaneous pump?
That's right. Yeah.
And what about the new medication? Do you have the Winreva? I forgot the name.
Yeah, correct. So
the new one.
The new one, yes. So a couple of months back, I signed off because they need a head of department to sign off. Yeah, so I just signed off one. Yeah, but cost is an issue. So
yes.
Yeah.
But do you have other patients, own patient using this?
Yeah.
And do you see any improvement?
I don't know because this is so we have a pulmonary arterial hypertension group. There's just 2 of them. So they are the one looking after all these patients with the pumps. Majority are on oral treatment actually. Yeah.
So belongs to other group of yes. Because we a little bit stuck with this group of patients. Yeah.
It's a very high cost.
In term of yes treatment costs and even the medication supply. Yes. Very limited.
Correct.
In Vietnam.
And in Singapore, 1/3 of our population are foreigners, as you know. And we continue to make these diagnoses among the foreigners, and we kind of have 2 groups, the white collar and the blue collar. So if we make the diagnosis in the white collar, they are usually they have a very good insurance coverage. But for the rest of the blue collars, those who are here to do sort of more menial job is the only thing we give them is in the end just oral sildenafil. Yeah, because the generic is very affordable. Yeah, treatment effect is not great.
Yes, the same here. The insurance cover very low cost. Yes, generic, and the effect is completely different with the brand. The patient themselves, when they have the brand and the generic, they can they admit that it's different. They feel different, but the insurance cannot cover the brand medication. Because when the right heart failure is advanced, the patient, he is still the left ventricle is still very not too small, but in case the left ventricle very small and easy for them to faint. Just a little bit exercise and they have syncope. Yes, low blood pressure, and in that case we cannot use too much diuresis, and it's very difficult to treat that group of patients. Yeah.
Do you have a dedicated pulmonary hypertension specialist? No. Or everyone manage pulmonary hypertension? Yeah. So you have special interest in pulmonary hypertension? Yeah. Oh, okay.
My PhD thesis related to pulmonary artery.
Yeah. Mm.
So I have met person with this condition.
How many do you have in your practice?
Yes, now I have more than 100.
Oh, okay. Yeah. Mm. Yeah. 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 They are the most tricky patient, you know.
The most difficult for the PH patient in Vietnam is prior medication. Treatment in Vietnam is too high, very, very high. Now the insurance cover a little bit, but not much. So.
Can you find causes for all these PH patient, or you can't find most of the time?
So cause
Yeah.
that's why I asked you about genes, because when we do all the stuff like left heart or CTAP or rheumatology or bronchology, we cannot find any cause. So we have to think of idiopathic, and we have some patient with family. Mother and son or father and daughter have the same disease.
Do you do MRI on all these patients, or you don't?
MRI?
No.
No.
No. Okay. But you definitely need to rule out the rheumatological causes and the autoimmune causes.
We seek advice. We ask them to come to. Usually, we do the panel for the interstitial.
Or you run the clinic together, multidisciplinary clinic. You know, rheumatology, cardiology.
Actually, we don't know. We haven't had a PH center, so we have to discuss with. Yeah, and that's why patients with PH now they can not belong to the cardiologist, but sometimes they with rheumatologists and sometimes with I think.
Okay. So, but if you have to form a group,
allergic,
a team,
allergy.
If you have a team or even a pulmonary hypertension group, or even a pulmonary hypertension center, it's easier for you to justify to apply for funding for all these patients. You know.
Right now we have some. We have tried some multi-center trial. Like I think the in the past when I had chance to come to Singapore, the professor in PAS said most of the patients get a benefit from the trials. They have new drugs.
James, our boss.
Yes, James, exactly. Yes. So about 10 years ago, I went to his clinic and he gave lecture and told us about this. And now I think he's still use the trial for the patient to get benefit from new medication, new drugs, because it's very high cost.
Yeah, so I think rare diseases treatment is always difficult because of the cost. So I had the opportunity to speak to, was it yesterday, talking about tafamidis and vutrisiran for cardiac amyloidosis, and I think it's not available. Is it? Yeah, correct. Because those are very high cost. Yeah, we did a short sort of a symposium on strain. So it is not focused today, but we just want to say that for anyone with septal wall thickness of 12, we turn on strain, and we just by doing that, we actually converted about 3%, around 3% of our diagnosis of hypertrophic cardiomyopathy to cardiac amyloidosis because of the clear apical sparing pattern. Yeah. So, but then you add on more problem, because now you have more conditions that has a very expensive treatment, and then they just line up one by one.
That's right. When we diagnose patient with amyloidosis, is maybe the doctor will know about the disease, but it's one more, like you said, it's very difficult because we don't have a treatment option for them. Yes, it's very expensive. Pressure.
Maybe we just spend a few minutes just to go through the features of primary hypertension. And
so now you will help us to give some analysis about this case. Thank you.
Test. It's okay. None. So I think the for this patient, from the very start, as we put down the probe, we can already see that the LV is being compressed and the right ventricular is very big. So then we go to the the RV inflow. We can take a look at, it's actually TR. And I think from here, it doesn't look very high yet, maybe about 4, but later on we actually got a higher Vmax. You can't really see, the valve looks okay, it doesn't seem like there's any problem with the valve. I cannot get any PISA here, but later on we realized that actually there is more than one jet. There's more than one TR jet in this patient. In the short axis, you can see, even without measurements, you can tell that the right side is very big, very dilated. You can look at your PA, it's huge. And let's take a look at the there. So This is the house wave here, and I think this is the one that you're talking about, right, Prof? The notching.
I don't think there's a notch.
So far looks okay. The CW.
Definitely, we can look at the acceleration time. So from there, we can actually calculate using the MAH, which is 79 minus.
So let's know. This is here.
The fourth context now better.
Yes, I want the slope. So this one, right? You want the slope here. This you wanted the slope, right?
So if you 0.45, okay, this is half. That's it's half. But that would be give us the mean PAP of only 15. So not sure. Yeah, it looks a bit too low.
See, look again at the tricuspid regurgitation here. Wait, hold on. Yeah, so much higher of Vmax, maybe about 5.
About our PR.
PR? PR, yes, PR have.
Yeah, you can also use that to do your 4V squared plus your RA to yours.
No, after I think image 22 you can
You
get the
want
PASP. Quite nice.
The main diastolic and systolic. You can also use systolic minus the diastolic.
what you want me to measure here?
The mean. The
You want the
Yeah.
you want the slope, is it? No. I cannot really see the
Yeah.
here.
It's a PR.
Yes.
This so this is a diastolic. 4V squared plus.
You want to
Yeah. Okay, let's measure the.
Oh, you want to trace?
No, I just need to see the velocity here. You can kind of like, yeah. So 3. That's really high. So there are just two ways of sort of assessing your pulmonary pressure. So one is of course the your Vmax. So that's a PASP. Using the acceleration time of your PA, you can apply your Mahan equation. And here, on the other hand, if you just remember to add on your RAP, this is your mean, this is your diastolic using the PR signal. But I was surprised that I think 300 is a bit too high for a mean. But what is our PSP anyway? Almost 5 meters per second, right? Yeah, it's close to 5. Yeah.
Oh gosh.
Yeah, just close to 100. Oh, almost 100. Yeah. So more than 100. Okay. That's why if you use our PR signal add on to the RAP, we are getting our mean PA of almost 40 for about 40. That's really high. Anything more than 20 is a pulmonary hypertension. So it actually does add up.
And then there is yeah, the S prime is also reduced. Yeah, I can see that the S prime is reduced.
So the PA pressure better than severe? Yeah. No need to say anything for severe.
The top 6 seems okay though.
You get a fantastical number next week. Is she sinus? The lips, or they should put on the lipsticks?
Usually not yet sinus.
Okay.
Yes. Because until the blood pressure is still and the left ventricle is not too small, the patient will He's Pastor classes Pastor 2, and still have 2 babies. Yes, and the anti-probability just 200. So I think maybe in the next, without treatment, in the next 2 to 3 years, the condition may become more severe. Some patients with the SpO2 will become less than 90%, but right now she's above 95. Yeah, still it's compensate. Still in the compensate grade.
No pericardial effusion also. So,
Oh,
yeah,
yes, pericardial effusion is a sign of yes.
The 3D-EF is more than 45%, and the S-wave, the THÄT is good, is around 17, but the S-wave in the tricuspid analysis is very low. So how you can explain about that numbers?
Yeah, I think first of all, the endocardial border tracing on the RV is suspicious. Yeah, I think we need to take that with a pinch of salt, and yeah, correct. So it's actually tracing some image.
THÄT is also just single plane, so not very reliable, just a surrogate. So you have to always be careful they're not caught by the normal THÄT.
But if you look at the RVS prime on the tissue Doppler imaging, the S prime
and it's
is
quite low. According to Julie, 6 or 7, so it's very low.
Correct.
So
it should be 12, 13, and anything less than 9, 9.5 is already low. This one is 7. It's pretty low.
And I can tell that the fraction area change also low, Yeah, eyeballing, rather than calculation. So again, it's another marker of severe RV dysfunction. Yeah.
Right. And not to forget that the RV dysfunction in this case is no matter how we measure, it will be underestimated because there's kind of like flow out from the tricuspid valve. So it does look like it does look better than what it ought to be because the RA pressure is probably going to be quite low. Yeah, it still have some outflow vent for the RV.
So did you? So what do you think is the final grade on the TR? Do you think it's moderate?
It's a bit more than moderate, yeah.
It's slightly more than moderate, but not severe yet.
Correct.
Just to add on, in our center, we always have this grade of moderately severe, so it's in between moderate and severe. Same for mitral regurgitation. We use a regurgitation volume. If it's a regurgitation volume between 45 to 59, we always quantify as moderately severe. Yeah. Anything above 60, we say severe. Anything below that, and then with the EROA in between 0.3 to 0.4, we always say it's moderately severe. So, because I think to us it's a big jump from moderate to severe. So, yeah.
So we finish with this case because the time is close. The time usually, yeah. Um, Last 10 minutes. You must leave at 3 p.m. So we we will change the program. We will first on behalf of the hospital and all the doctor here, we would like to thanks for the sincere thank for the time, very precious time, and the lectures you and Professor Kong have delivered to us today. And you have a very busy day, and right now you have to leave. So we just want to have a small present from the hospital to memory the first time you come to our hospital, and we really hope we will have the future opportunity for collaboration and to learn more about not only the practice but other aspects related to imaging and maybe some opportunity to exchange doctors to come and visit your hospital and learn the real practice in the hospital. And we really hope you will have a very safe flight back to your countries. And we would like to have a group photos of all the class with you because the very intensive 1 day course, and after that we will lecture more. Thank you.
Nice, yeah. Thank you.
I would like to invite you to come here and have some.
So we also like to say that we are very touched by the hospitality yesterday with Vinman and today in the University Hospital. And we again, I'd like to thank Phillips for making this possible. So yeah, indeed, I think we can all learn from each other. The different kind of cases, different way of managing cases given our challenging real social circumstances and differences. Thank you so much.
Thank you very much.
It smells nice.
Please join us.
Vâng, xin mời quý vị chúng ta thì lên sân khấu để chụp hình kỷ niệm cùng với chuyên gia của chúng ta. Vâng, xin mời toàn thể quý vị ạ. Chúng ta sẽ cùng lên sân khấu để chụp ảnh kỷ niệm và sử dụng tập thể cùng với các chuyên gia của chúng ta. Và chúng ta có thể mình thành hai hàng biểu đạo ở phía trước thì những người khác chúng ta có thể đứng thành hàng ở trước, và các quý vị càng cao hơn thì chúng ta có thể đứng phía sau một chút và có thể ngóc cái chân của mình lên. Và xin mời toàn thể các sinh viên an toàn vệ sinh dưới chúng ta cố gắng lên đây để cùng chung vui và chụp một tấm hình kỷ niệm tập thể của hội thảo CHÄN ngày hôm nay. Yeah. Trước với tay ạ, trước với tay ạ. Cảm ơn. Vâng, quý vị thân mến, thì sau phiên hội thảo với những nội dung chuyên môn sâu sắc và những trao đổi học tập đầy giá trị, thì chúng ta sẽ dành ít phút để nghỉ giải lao. Và trong buổi tiếp thì xin trân trọng kính mời quý vị của chúng ta sẽ thưởng thức trà và cà phê ở phía giải thiệp. Và đây cũng là dịp để quý vị thư giãn như là giao lưu và tiếp tục trao đổi những kinh nghiệm chuyên môn cùng các đồng nghiệp.
It's fine. These 2 days.
Yeah.